Thank you, Chairs, and a very good morning to everybody. Next couple of minutes, I will run through a couple of articles published last year, and let's start with this. Tranexamic acid in patients undergoing non-cardiac surgery. So worldwide, there was over and all more than 600 million patients who are suffering from different kind of bleeding disorders and bleeding-related issues requiring transfusions. And there is a high time, there is a lot of scarcity and high time to optimize utilization of blood products. And there is a call from WHO for efficient patient blood monitoring also. So based on that, there are a couple of literatures coming up and trying to manage these patients with something else. So first is tranexamic acid. This is a RCT. So whether the question was rightly asked, yes, I think. Does tranexamic acid result in a lower incidence of life-threatening bleed or major bleed or bleed in critical organ compared to placebo, and also any major cardiovascular implications in within 30 days. And major cardiovascular complications, they mean to say any myocardial infarction, non-hemorrhagic stroke, kind of a thrombotic event they looked at. And whether they have chosen right population, it is an international RCT, 114 hospitals in 22 countries took part. Inclusions were patients more than 45 years of age undergoing inpatient and non-cardiac surgery and with some risk of bleeding, which they have specified. Intervention was tranexamic acid, 1 gram IV at the start and end of surgery, or placebo. A total of 9535 patients were included and randomized to both of the arms. 30-day follow-up was completed almost in 99.9% patients. And we see there is a definite reduction in the tranexamic acid arm, which was statistically significant also. So for that, this is definitely superior. However, this is the forest plot, and you can see in composite cardiovascular outcome that did not, they tried to see the non-inferiority, which they could not prove actually. So while deciding about giving tranexamic acid to patients, healthcare provider may have to think about certain a small increase in the incidence of composite cardiovascular outcome also. The next is tranexamic acid in trauma patient, which is severely or non-severely injured trauma patient. And it is a meta-analysis of RCTs, and primary outcome was survival on the day of injury, and secondary was at 28 days. It's black হয়ে গেছে. 28 days, and they also looked at fetal thrombotic outcome. By severe injury, they mean systolic blood pressure less than 90, heart rate more than 120, GCS less than 9, or any GCS with fixed dilated pupil. Okay, so survival at 24 hours, definitely it favored tranexamic acid, and tranexamic acid significantly increased the survival on the day of injury, which was their primary outcome. They have considered these two trials, basically CRASH 2 and 3 trials, which looked at bleeding trauma patients and isolated traumatic brain injury patients, respectively. And it is seen that if there is any delay, that increases delay in tranexamic acid, that increases we lose in survival benefit, and that is more prominent in non-severely injured patients. There is no increase in incidence in fatal or non-fatal thrombotic event. Another article on tranexamic acid, systematic review and meta-analysis on GI bleeding. And we face this problem a lot of time, particularly when patients are taking antiplatelets and anticoagulants. They tried to understand whether there is any mortality benefit at the latest follow-up, and secondary outcome includes any bleeding outcome, rebleeding, or any thrombotic events. So they have taken 12 studies, 12 RCTs, and 5 studies has taken given high dose of tranexamic acid, and 7 given lower dose. Higher dose did not reduce mortality or risk of bleeding. However, lower dose, there is some reduced risk of rebleeding was seen, and there is significantly lower risk of death. So from these, we can think about high-dose tranexamic acid did not improve the mortality. However, low-dose or enteral tranexamic acid may be effective in reducing hemorrhage, but more evidence is necessary to confirm this finding. Next, we go to platelet transfusion. Prophylactic platelet transfusion. This question we face a lot of time bedside, whether we give platelet transfusion after a certain lowering of platelet values, and not much of literature on these. So there is a systematic review with meta-analysis on this. The study questioned were benefit or harm of prophylactic platelet transfusion versus no prophylaxis on outcome of hospitalized patients with thrombocytopenia. Primary outcome was all-cause mortality, and secondary outcome was clinically important bleeding, nosocomial infection, and other things also they have included. The problem is they have taken data from 1980 to 2017, almost 37 years of data they have included. And there was a lot of heterogeneity in these research papers. And for that, basically, there was the benefit was not found out. This was the forest plot, primary all-cause mortality, which did not favor prophylaxis. However, the forest plot for secondary outcome of clinically important bleeding, that there was some favor towards prophylaxis. So, but however, whenever they have gone through all the details of this heterogeneity analysis and all the analysis for this meta-analysis, the result remain uncertain for all-cause mortality at longest follow-up, and there may be some benefit for bleeding. So in this area, we need more research, especially targeting this part. Next is safety and efficacy of anti-10A guided versus fixed dose low molecular weight heparin for prevention of VT in trauma patient. Again, a systematic review and meta-analysis. The main target, because there is a lot of mortality and morbidity associated with this. So they tried to see a comparative efficacy and safety, and included all adult patients who are on low molecular weight heparin, anti-10A guided versus heparin dosing versus fixed dosing. And they have taken studies which evaluated clinical efficacy and safety also. And main outcome, they looked at DVT, PE, VT, any mortality and bleeding events. So they have taken 15 observational studies, and several studies have fixed their target for anti-10A peak in these ranges. And according to their analysis, most studies were judged to be of low risk of bias. This was any venous thromboembolism, which favors anti-10A, DVT, which favors anti-10A, and the median VT incidence was around 4.9%, which was little higher when they used when the studies used ultrasonography, and pulmonary embolism also favors this side, the anti-10A guided dosing. So compared to fixed low molecular weight dosing, anti-10A guided dosing probably will reduce VT, or any DVT. But for mortality and bleeding events, there was uncertain results. So for this could not be commented on. Next, two literature is on this part, viscoelastic hemostatic assay. One is for resuscitation of trauma patient, again a systematic review, and they tried to see blood product usage, mortality, hospital length of stay, ICU cost, serious adverse event like thromboembolic event or sepsis, and they have included RCTs or observational studies which basically compare the two. One is guided by TEG and ROTEM, and other is by other protocols or conventional clotting tests and or pre-TEG ROTEM protocol in adults. So overall risk of bias assessment was moderate to severe, but there is no significant difference in transfusion of RBC and other blood product and mortality between these two groups. So VHA guided strategy probably will benefit reducing the need for blood transfusion and mortality, but still evidence is not robust. Another thromboelastography guided therapy, but in this time it is cirrhotic patients and meta-analysis on RCTs. And that is to determine whether thromboelastography in adult patient with cirrhosis decreases blood product use and impact adverse event or mortality compared to standard practice. And primary outcome was number of transfused platelets, and secondary outcome they have included mortality and other issues. And they have seen the utilization definitely has gone down, especially this platelet, most prominently on platelets. And there is mortality difference at day 7, and that also favors thromboelastography. So it was associated with less blood product, usage of less blood product, especially platelet. No differences were reported in bleeding rates, and thromboelastography group have lower mortality at 7 days versus control. Now, this issue we see a lot of time in our daily practice. First day hemoglobin is 11, second day hemoglobin is 9. We do not understand, and sometimes we think that it may be a cause of case of anemia. Actually, we try to give rapid fluid boluses to enhance cardiac output to help the patient, but actually the oxygen delivery may not be improving. So in that case, there may be a problem. So they try to see at meta-analysis where they try to see whether there is rapid decrease in hemoglobin before and after administration of resuscitation fluid. And 63 studies were included, and it was seen a mean of 1.33 gram per deciliter hemoglobin drop. And it is more marked in non-acutely ill patient, and especially up to 1,000 ml of transfusion. So we see non-acutely ill patient, there is more decrease compared to acutely ill, but in all subgroup analysis, there is definitely a decrease or reduction of hemoglobin. So hemoglobin decrease consistently after rapid fluid administration with moderate certainty of evidence, and effect may limit positive effect of fluid challenge on DO2 and thus on tissue oxygenation. Now, quickly on glucose control in ICU. It is an RCT. The effect of a liberal approach of glucose control in critically ill patients with type 2 diabetes, a multi-center parallel group open label RCT. they tried to see the effect of liberal approach, and by liberal they mean intervention group IV insulin was commenced at blood glucose level more than 252 with a target of 180 to 252, and otherwise it was more than 180 and with a range of 108 to 180. Primary outcome was incident of hypoglycemia, and secondary outcome includes glucose metrics and clinical outcome. Sorry. So they could achieve this primary outcome. There was one episode of hypoglycemia occurred in 10 out of 210 patients, that is 5% in this intervention group, but it is 18% in the other conventional group, but not much of patient-centered outcome. So there is actually a little bit increase in the mortality. So patient-centered outcome did not improve. Again, there is a question. And this last one, the glycemic control in critically ill patient with or without diabetes. It is a retrospective analysis of EICU database, and primary outcome was hospital mortality. I have taken this study. It has included more than 52,000 patients in their analysis, and on diabetes patient exhibited a J-shaped association between time-weighted average glucose and hospital mortality. This is non-diabetic, the blue one, and it has got little flattened curve. But mortality is lowest in this region, and that would be the glucose range, where below average risk of mortality for non-diabetic it is little lower, and for diabetics it is little higher. So the key message is tranexamic acid will be beneficial to arrest bleeding in non-cardiac, non-neurologic surgical patients, trauma patients. However, healthcare provider needs to assess cases at risk of thrombotic complication, and for GI bleed, more research is needed. Second, prophylactic platelet transfusion may reduce clinically important bleeding in hospitalized patient, but evidence is very uncertain still now, and generalizability to all patient population is still unclear. Promising evidence of for the use of anti-TNA guided dosing, but however, we need to be more certain about the safety outcomes, which this study could not prove actually, and mortality and bleeding issues. And beware of a drop of hemoglobin during fluid resuscitation. And lastly, controlling sugar remains a challenge in ICU, and a target level may vary for diabetics and non-diabetics. Thank you.